The smell reached the physician before he reached the patient. Not the ordinary rot of a battlefield wound, not sweat and blood and old linen. Something else. Closer to earth, left standing too long in still water. Swedish at the edge and wrong all the way through. He already knew, before he pulled back the cloth, what color the leg would be. Black, not bruised, not pale from shock or blue from cold. Black the way meat goes black when the life has entirely left it. The kind of black that tells you something that was once a living part of a person has stopped being either. This is what ancient doctors actually saw. And what they did next was not superstition, not theater, not guesswork dressed in authority. It was the product of centuries of observation by people who had no other instruments except their own eyes and hands and the record of everyone who had died before this patient. You are going to watch them think through it. You are going to understand why their logic was, in its own terms, precise. First, what a black limb actually was. The physicians of antiquity and the medieval world did not use the word gangrene the way you use it now, as a clinical category with a known mechanism. The term itself is Greek, gangrena, meaning something that gnaws. Galen used it in the 2nd century to describe tissue that had passed beyond inflammation into dissolution. Celsus, writing in Latin in the 1st century, distinguished between the gangrenous and the sphaculous, the dying tissue and the fully dead, and the distinction mattered to him the way the difference between a wound still bleeding and one already dry matters to a surgeon. Different states, different logic, different response. What caused the blackness varied, crushing injuries that cut off the supply of blood to a limb, wounds gone septic, the infection spreading upward through flesh and threatening the whole of the body, frostbite, which the armies of every northern campaign knew intimately, venomous bites, tourniquets tied too tight and left too long, diseases affecting the blood vessels, which the physicians named imperfectly but recognized by their outcome. In almost all cases, the final common picture was the same. Tissue that had been deprived of whatever it was that kept tissue alive had stopped living, and dead tissue inside a living body was not neutral. It was active. It was a problem that moved. The first layer of diagnosis was sensory, methodical, sequential, physical. A physician examining a black limb in 5th century Greece or 2nd century Rome or 13th century Alexandria would begin by looking at color. Not just the black of the worst area, but the gradation outward, the pink of living flesh, the gray of tissue in distress, the boundary line where one shaded into the other. Then he would smell. The odor of necrotic tissue was well documented, commented on in the Hippocratic corpus, and recognized as an indicator of how far the corruption had advanced. Then heat. The dead area would be cool, the surrounding tissue perhaps hot with fever or inflammation, and the contrast between them told you where the process was active. Then pain, or rather its absence. Living flesh protests. Dead flesh does not. A probe to the blackened area that produced no flinch, no withdrawal, nothing. Confirmed what the color had already suggested. Some physicians checked for pulse at the periphery of the limb, the foot, the wrist, though their understanding of what a pulse meant mechanically was imprecise by modern terms. The point is that none of this was casual. It was a system of evidence. What frightened the physicians was not the dead tissue itself, but what it did to what was still alive. Hippocrates, writing in the late 5th century BC, understood gangrene as a failure of the body's vital heat, the principle that maintained life against corruption. Once flesh was judged dead, it would putrefy, and putrefaction was not local. It spread. The fever that followed a gangrenous limb was understood to be the body overwhelmed by what the dead part was releasing into it. Celsus described this progression explicitly. The corruption ascends, the patient weakens, the fever climbs, and eventually no intervention can stop it. You did not need to understand bacterial toxins to observe the sequence accurately. They observed it accurately, they wrote it down, they built a decision around it. The decision was never simple, never comfortable, never made from indifference. Doctors in this period were not choosing between cruelty and kindness. They were choosing between different injuries with different survival odds and no certainty about any of them. Let the limb alone, and the corruption might spread and kill the patient. Intervene, and the intervention itself might kill the patient. Every tool they had was crude, every outcome was uncertain, every choice was made against that uncertainty by a physician who had watched people die of both decisions. So when they made a choice, it rested on everything the senses had gathered, everything the dead flesh announced about its own state, and everything the men before them had recorded about where this particular picture usually ended. And what they chose next requires its own accounting. The first intervention was not the knife. The knife was not even the second. Before anything was cut, a physician would attempt to hold the line, to arrest the spread at the boundary between living and dead tissue rather than remove what had already been lost. Celsus, whose first-century encyclopedic work De Medicina is one of the most detailed surgical records to survive from the ancient world, described the use of caustic substances applied to the edge of the necrosis, salts, resins, preparations strong enough to destroy the tissue they touched. The logic was not random cruelty, it was containment. Burn the border, stop the progression, buy the body time to recover what it could. This is the first beat to hold on to. Ancient physicians were not reaching immediately for the most violent option. They were reaching for the least violent option that might still work. But when caustics failed, or when the picture at presentation was already beyond salvage, something sharper had to follow. Debridement is the clinical word used now, the removal of dead or contaminated tissue to protect what remains. The concept has a different word in Celsus and in the Hippocratic writings, but the action is the same. Cut away the dead, give the living a chance. A physician examining the margin between black and viable tissue would cut into it, and the cut itself told him something. Living tissue bleeds. Dead tissue does not. The line between the two could be found by the instrument, adjusted as the work proceeded, revised if the first estimate was wrong. This was not surgery in any sense you would recognize from a modern theater. There was no anesthesia beyond what wine or henbane or mandrake preparations could provide, and their efficacy was inconsistent at best. There was no sterile field. There was a blade, a patient who had to be held, and a physician who had to work quickly and read what he found as he went. What sometimes actually worked here is worth naming carefully. Removing necrotic tissue does reduce bacterial load. It does eliminate the substrate on which infection continues to expand. This is not a modern insight delivered retrospectively onto an ancient practice. It is the reason the practice survived and was transmitted. The physicians who debridged early enough and completely enough watched some patients survive who might otherwise not have. They recorded it. They passed the observation forward. Galen, working in the 2nd century as physician to the gladiators of Pergamon, had more exposure to traumatic wounds than most physicians in history, and his notes on wound management reflect exactly this pragmatic pattern. What I tried, what the wound did, what the patient did after. Dressings came next, and here the picture is mixed in ways worth being honest about. Wine as a wound wash appears across sources and cultures, and there is a real mechanism beneath it. Alcohol is antimicrobial at the concentrations found in wine, though inconsistently effective and far weaker than what modern medicine would use. Honey, applied to wounds by Egyptian practitioners as far back as the 2nd millennium BC and still appearing in Islamic medical writing, including in Ibn Sina's 11th century canon of medicine, has genuine antibacterial properties. The high osmolarity of honey draws moisture out of bacterial cells and creates an environment hostile to infection. The people applying it did not know this at the level of mechanism. They knew it from outcome. The wound treated with honey sometimes did better than the wound left without. So the observation survived, carried inside a theory that explained it incorrectly, doing real work regardless. But now the case that brought us here, the limb already fully lost. If the black extended too far, if the smell had advanced, if the patient's fever was already climbing and the dead area was clearly joined to the living by nothing except anatomy, a different calculation took over. The limb had to come off, not as punishment, not as theater, as arithmetic. One person entering surgery with a dead leg had 2 possible exits. Leave it, and the systemic spread would almost certainly kill them. Remove it, and they might survive. The odds for amputation were not good. The odds without it were worse. The physical reality of amputation before 1846, the year ether anesthesia entered surgical practice, requires the restraint of plain description rather than embellishment. The patient was held or bound. The cut was made through living tissue at a level above the necrosis, where the flesh bled and the patient felt everything. Speed was skill. A competent military surgeon could complete the removal of a limb at the thigh in under 2 minutes. Ambroise Paré, the 16th century French surgeon who served through the Italian wars and wrote more candidly about surgical practice than almost anyone before him, described amputation as the last resort of a physician who had exhausted every other possibility. He also, in a modification that matters, replaced the standard practice of sealing the stump with boiling oil by ligating the blood vessels with thread. Not because a theory told him to, because he ran out of oil after the Battle of Turin in 1537, used a digestive of egg yolk and turpentine instead, and found in the morning that those patients were in less pain and doing better than the ones treated the traditional way. Observation over orthodoxy, the logic of someone who kept watching. Guy de Chauliac, the 14th century surgeon whose Chirurgia Magna shaped European surgery for 2 centuries, wrote that a surgeon who does not know his anatomy will cut where he should not. The point is simple, and it keeps resurfacing. These were not men working in ignorance of what they were doing. They were men working at the edge of what their knowledge permitted, revising when the revision was permitted by evidence. Which brings the easy condemnation to a stop. The assumption that ancient surgeons were simply brutal or simply wrong rests on forgetting that they were working inside a coherent system that made predictions and tested them against outcomes, with stakes high enough to enforce accuracy. Humoral theory was wrong about mechanism. It was not wrong about observation. A patient whose corruption was ascending past the knee had a worse prognosis than one whose corruption was limited to 2 toes. They knew that. They wrote it down. The theory that housed the observation was a container that needed replacing, not the observation itself. What you're left with, when you stand where they stood, is this. A physician in Alexandria in the 2nd century and a surgeon in a Crimean field hospital in the 19th century were both working the same problem. Stop the spread. Save the person. Make the decision before the decision is made for you by the body's own arithmetic. The instruments changed. The mechanism was understood more accurately. The odds improved. But the fundamental act, looking at where living tissue ends and dead tissue begins, and deciding what to do at that line, is the same act. Modern surgery still performs debridement, still uses honey-based dressings in some wound categories, still makes amputation decisions on exactly the logic Celsus outlined in the 1st century. The corruption ascends, and you must decide how far you will let it go. The black limb that opened this story is still the thing a surgeon assesses before anything else. The smell, the color, the heat, the presence or absence of pain. The body still announces its own condition in exactly the same register it always did. What changed was the precision of the response. What did not change was the observation underneath it. The physician who reached the patient before the instrument reached the patient, who read the evidence before he acted on it, who made a terrible choice because the alternative was worse. He was not primitive. He was practicing. And everything he got right is still in use.